Hello, my name is Lee Presser. This is my show. I speak frequently to very interesting people. Some of these conversations are so exciting, so intellectually stimulating, I thought others might like to listen in. This is the reason we started recording Conversation with Lee Presser.
Welcome to Conversation with Lee Presser. On March 21st, 2010, the United States House of Representatives voted 219 to 212 to accept the language of the Health Care Reform Bill passed on Christmas Eve 2009 by the U.S. Senate. President Obama signed the bill into law. June 28th of 2012, the United States Supreme Court confirmed the constitutionality of the Affordable Care Act. Almost no one who voted yes or no on the health care bill fully knew what was in it. Nearly 3 years later, we're still trying to learn what some of the phrases and clauses in the bill will mean to those seeking medical services. To help us understand how this bill is affecting your current health insurance plan and the changes to it during the next few years, we're going to speak with our guest today, Ken Schmidt, a healthcare insurance broker who specializes in individual, senior, and small healthcare group plans. Ken Schmidt, welcome to Conversation.
Thank you for having me.
So, it's called the Affordable Care Act. Is that correct?
Yeah.
That was the title on it. It's not. Everybody calls it Obamacare, but it's not. It's the Affordable Health Care, the Affordable Care Act, and it's already somewhat in force. So why don't you start by telling us what you know about this bill and how it's working?
Well, originally it was called the Patient Protection and Affordable Care Act, and then they said, don't call it that because it's too complicated, call it the Affordable Care Act. And now they say call it ACA. But a lot of people, including the president, call it Obamacare, but I'll call it the Affordable Care Act.
Is it affordable?
Well, the thing that I think that it is not is affordable. So, and we'll talk about that. I actually was at a meeting the other day, and I had one of our one of Missouri state senators, two people from the hospital industry, both of them from the big hospital systems, and then from a business organization. And I asked the question, how do you insure 50 million more people, which is approximately what we have in the number of uninsured right now. So how do you insure 50 million more people? How do you give them better benefits, which Obamacare does increase benefits for the people that have insurance and for the people that don't have insurance? And how do you have 50% of Americans, only 50% of Americans paying for it? And the answer was, it can't be done. So I think the one thing that the Affordable Care Act is not affordable. Now, whether we have it, and we do have it, and it looks like we're going to have it and have to live with it unless something changes. As you know, I mean, the Supreme Court really, what was really looked at was the individual mandate. That's the 26 states filed a lawsuit with regards to it. And the individual mandate was what really came into question. In fact, in Missouri, in August of 2010, we passed a law saying that we're not going to make people take health insurance.
An individual mandate to do what?
To take insurance. So people will be required to take health insurance in the future. That actually starts in 2014, where everyone will be required to have health insurance. Now the question becomes is how do they pay for it? But they will be required to have it. In fact, they will be penalized if they don't have it.
So like some 27-year-old young man who's healthy and doesn't have a job that provides him with health insurance, under this law, he or she is required to go out and buy health insurance. They don't have an option any longer.
They don't have an option
starting now or starting in the future?
Starting in 2014, they won't have an option.
So next year.
Right. Now the penalty in 2014 is $285. Now I would argue that that's not even a slap on the hand, because $285, somebody will say, well, I'll pay the penalty and I still won't have health insurance because I'm that young, invincible. Unfortunately, what happens over the next 2 years then, the penalty goes up to $975 in 2015, but it goes up 10 times to $2,085 in 2016. So at some point in time, we're going to get people insured because we're going to penalize them and they're going to pay penalties if they don't do it. How they're going to administer the penalties and all that is really a question mark right now, but that's what the penalty will be. It'll go up to $2,085 in 2016.
So within 3 years, people who don't have insurance today because they don't want it, not because they can't afford it,
Right.
they just don't want it because they don't want to spend the money on it, they won't have a choice any longer. They have to have a plan. Now, does that mean they go to like Anthem or Blue Cross, or are we talking about that they have that? And I'm maybe out of my depth here. Or is there going to be some federal system, a federal insurance program like Medicare?
Well, several things happened in 2014. So, I mean, we're in 2013 now. So if I can step back, one thing that maybe the viewers would like to know is that right now you can deduct medical expenses up to 7.5% of your income. That's going to be raised to 10%. Unless your medical expenses are over 7.5% of your income, you can't deduct them. Now it's going to be raised to 10%. So that is an impact on people that maybe were deducting medical expenses in the past. They'll have to have more expenses. In 2014, lots of things happened. That's the big date. And depending on which side of the aisle you're on, you would say this is a really good plan or this is a sinister plan. And the good plan or the sinister part of it is that the good things that people liked already have occurred with regards to the ACA or the Affordable Care Act. For instance, age 26, kids can stay on their parents' plans.
This started in 2012.
Yeah, well, that's already there, yes.
Right. So kids up to age 26
can stay on their parents' plans.
What if they weren't on the plan? Can they still go back on the plan? Or is this a case of if you were on mom or dad's plan, you can stick with it to your 26, but you can't go back onto it.
No, you can get back on it. I've had situations where somebody was in school, out of school, back in school, whatever. The irony of this thing is you can even be, for instance, you can be married and still be on the program, okay? Still be on your parents' plan. So
really?
The administration has touted that this has insured 1.3 million, people in that age bracket. And I think, in my opinion, that's kind of disingenuous because that implies that they wouldn't have got insurance otherwise. So it's somewhere between 0, I guess, and 1.3 million. It has helped, but a lot of people would have gotten jobs and gotten employed and gotten health insurance with that. In 2014 is when the big things start to happen.
Oh, wait, before you go there, is there anything going on in 2013 of any consequence?
Well, there's a lot of administrative things going on. And remember, you're talking about a 2,700-page bill. And these things are literally being written as we speak as far as the implementation process.
Rules, not
the rules and the regulations.
The law is
the law, but the rules that implement them so that they make it palatable for all the rest of us, so that somewhere down the road we can understand it and maybe get a benefet from it.
Now this is written by bureaucrats, not by legislators, right?
That's correct. What's happening now is the head of HHS, Kathleen Sebelius, is doing, her and her organization through Health and Human Services, they're the ones that are drafting all these implementation things. Something just came up in the paper just the other day where over the Christmas holiday, they brought 3 more implementation things that needed to be voted on by Congress. And I think it goes back to the Clinton administration where when you receive something that you're supposed to vote on, you have 60 days to look at it. Well, they've thrown that out. In fact, one of the bills, they had like 23 days to look at it. And these typically are hundreds of pages that they have to disseminate to figure out. And I guess the fact that a lot of them are lawyers, maybe that makes it easier for them, but it's a lot of verbiage that has to go through in a short period of time. The things that are so there's a lot of administrative things going on every year, okay? In 2014 is really, I don't know if it's the banner year, but it's certainly the year where that's where things really need to happen, where things start to happen. First of all, that's where the individual mandated is in there. Also, that means what happens is insurance is going to be what we call guarantee issue, meaning that everybody can get insurance. Okay, no matter what their health is, pre-existing conditions, starting January 1st of 2014, everyone will be eligible for health insurance. That doesn't mean they can pay for it or will pay for it, but it means that they can get health insurance. There's not going to be any medical requirements. Now,
Pause for just
Sure.
a second. So people who, for whatever reason, maybe they'd had cancer in the past, or they've had some liver issues, or they've had kidney issues, and then they lost their insurance, and then they were looking for a new policy, say in 2010, and couldn't find it. You're saying that in 2014, that the insurance companies will be required now to offer it to them. Is that what, am I reading that right?
That's exactly correct.
Now,
So,
are you also saying that the companies have to offer that insurance to them at the same premium rates as somebody who has not had these pre-existing conditions?
no, that's not what I'm saying, because
Okay.
that comes back to this affordability issue. You know, you can't increase benefits. In fact, there's a provision in the law which starts in 2014 calls the essential health benefits, and those are basically 10 different categories of benefits that all plans have to have. And those I will tell you frankly, what's happened over the last few years with my clients is, what have they done? They've attempted to keep their costs down by modifying their benefits, in some cases reducing them, changing co-pays, changing co-insurance, raising deductibles or whatever to keep their costs down. Well, starting in 2014, there's going to be a blueprint with regards to what has to be covered under in every plan.
Now, are deductibles in there, or are they getting rid of deductibles?
No, deductibles are still there, but the highest deductible is going to be $2,000, which becomes problematic for people that have bought higher deductible plans because they're healthy. They still want to have health insurance, and they want to be protected in a catastrophic situation.
Right. Okay.
But now they're not going to be able to have those $5,000 and $10,000 policies. It brings into question health savings accounts, which was designed to have higher deductibles. So now the deductibles are going to be much lower deductibles, which means, when you increase benefits, I mean, this is, I don't understand that. People don't understand the economics of it. If you get more, it costs more, okay? If you get less, it costs less. So when you get more, benefits are going to be higher. So the answer to your question is, yeah, insurance is going to go up dramatically. You can improve benefits and not expect to pay more for them. This is not about what it's going to cost, okay? It's about what you're going to get. And what you're going to pay if you don't get it. So those are the kind of things. In 2014 also, you've got the health exchanges that are going to come out. You asked how people would buy insurance. Well, health insurance exchanges are going to be established. And there's going to be either a federal exchange, a state exchange, a private exchange, or a combination of federal and state exchanges.
What are we exchanging here?
An exchange, I described an exchange to a good friend of mine, and they said, isn't that what you do as a broker? An exchange, think of it as a marketplace, or think of it as a grocery store. You go in, and there's lots of different choices, and you pick the one that you like based on maybe taste, maybe cost, whatever the things that you decide on. Well, health insurance is going to work the same way, in one sense at least. There will be some pre-planned choices for you. The fact of the matter is that the bill reduces really the benefits in general. I mean, it says that all the plans are going to have certain benefits, and you're not going to be able to have better benefits or worse benefits. These are going to be the benefits, and there's going to be 4 different plans. And those plans are a platinum plan, which will be the best, and then a gold and a silver and a bronze. And depending on how much you want to be reimbursed, the benefits are going to be the same in all of them. But maybe the lowest plan will reimburse at 60%, and the highest plan maybe at 95%. But the government has decided that instead of all the choices that are out there now, we're going to limit the choices to make it easier for you and I to understand things. Now, for some people that's probably a great thing. But for a lot of people, they say, well, you know what, I don't want people deciding what my health benefits are. If I want better benefits and I'm willing to pay for them, why shouldn't I be able to get them? So that's going to be a controversy. As far as the exchanges goes, and really this individual mandate is going to be driving everything. And if you think of it, it's a big stick that the government is using and is holding over our head to hit us with. And there's basically 3 things that soften the blow of that hit. One of them is going to be Medicaid expansion. One of them is the exchanges, which I've already talked about, which is going to be partially subsidized by taxpayers. They say, when they talk about subsidies, they never say who's paying it. They just say subsidies. And then the last one is going to be by tax credits for small businesses. But basically, we're entering an environment where you're going to you're going to be able to get coverage, which is good for, the winners in this whole thing are the uninsured or the low-income individuals, because those individuals will be able to get insurance. Again, cost is a different issue, but they'll be able to get, in fact, they will be required to have health insurance.
So those people who we constantly talk about, oh, they're the ones who are showing up at the emergency room and using it like a doctor's office. They, in fact, will have an insurance policy. It's not like it's free anymore.
Right. Well, they'll either have Medicaid, which is free because we pay for it, okay? The expectation of Medicaid expansion, they expect Medicaid to expand to another 15 million people. Now, that's problematic in itself, because I deal with Medicaid individuals now, and the biggest problem they have is finding doctors that will accept them, because the Medicare reimbursement, the Medicaid reimbursement is so low that doctors don't want to take them. I mentioned to you when we spoke the other day, I had a knee replacement, and I asked the physical therapist about, how much it costs for, how much he needs to make each time a patient comes in, and he said $65. I said, well, how much does Medicaid reimburse? And it was like $25. So he can't afford to have Medicaid patients. He needs to have patients that he's going to at least receive the $65 from.
Now, is the new law going to require him to take the $25, or is it still up to the doctor or the therapist as to who they will see and who they won't?
It's not going to require them to take it, okay? Now, what the administration has said is that what they intend to do as part of the Affordable Care Act is raise the Medicaid reimbursement level, but at the same time lower the Medicare reimbursement level. Now, I don't know how you do that with 8 to 10,000 people every day turning 65 for the next 15 years. I don't see how much you're going to be able to take away benefits from seniors. But that's one thing that the Affordable Care Act does. It takes away about $716 billion from Medicare over from 2013 to 2022. So, it's taking a lot of it away, and that's going to be taken away in plan choices, it's going to be taken away in benefits, and it's also going to be adjusted with regards to this reimbursement that we're just talking about.
So Medicare, that's the one that's for 65 and older.
Typically,
Medicaid are poor people who are under 65.
That's correct.
Okay, so monies are being shifted from the over 65s into the under 65s?
That's correct.
What you're saying?
That's correct. Now, the expansion of Medicaid doesn't solve one big problem that we have in this country with or without the Affordable Care Act, and that's the lack of doctors. Or the lack of there's not enough doctors to see all the patients. And if we're going to expand the Medicaid situation, you're going to put 15 more million people into the Medicaid situation, where now they have some type of insurance. Okay, but the government's, we as taxpayers are paying for that insurance. But it's obvious that the medical system is going to be overwhelmed in this. It's probably why back when the bill passed, the Physicians Foundation did a study, or did a survey from their members with regards to the Affordable Care Act, and 40% of them said, I'm either going to retire or I'm going to get into a non-clinical situation where I'm doing research or something where I don't have to deal with patients. Or I'm going to get out of the doctor's profession altogether, because we don't like this. Because what ultimately is going to happen when the government starts controlling reimbursements, and I'm not trying to plug how much doctors should make or whatever, but when the government controls them and they control them downward, to become a doctor, not only does it take a lot of time and devotion and everything else, but it also takes a lot of money. It's a very expensive thing to become a doctor, and even more expensive today than it was many years ago. And you have literally hundreds of thousands of dollars of debt, and how do you ever pay that back if your reimbursement levels are continued to be reduced? So, there's lots of...
It's interesting you say that. I was just speaking to my doctor just 2 weeks ago. And I asked him that very question, because we were talking about something, and he had gone to, I think, WashU School of Medicine, and he was comparing, what he wound up paying to go there and the amount of debt that he racked up back, a number of years ago, compared to some of the young people who are coming out and wanting to join his practice. It says like 5 times as much.
Right.
Something on the order, I forget what he said, how many tens of thousands of dollars per year to go to medical school.
So, this Medicaid, so the ways to get it, the Medicaid expansion, is, I guess one thing that concerns everyone is that, okay, so we have these Medicaid participants, but no doctors want to accept them. And then I still see today Medicaid patients, for the most part, are still forced to do what illegal or undocumented immigrants are in this country, and that's to use the emergency room as their main or only source of health care. And as many people know, that's the most expensive place to get health care. It's guaranteed. As we talked about the other day, in 1986, Congress passed a law called EMTALA, and that says that anybody walking into an emergency room can be treated in an emergency situation, regardless of
whether
age,
it's an emergency
sex,
or not.
Yeah, age, sex, propensity to pay,
Yes.
citizenship, any of those things can't be taken into consideration. So it's kind of a, that puts a big pressure on the hospitals and I guess the insurance companies. This push for Medicaid, which has come up just recently, one of the reasons that the hospitals are so far this Medicaid expansion is because, think of it, they're treating all these people right now that don't have insurance. Well, if they have Medicaid, then they have insurance. So we're paying the bill now. So instead of transferring those costs to either writing them off or to transferring them to the private insurance industry, now they'll be able to bill the government for them, which ultimately is the taxpayer. Mm-hmm. In my estimation, the biggest loser in the Affordable Care Act is the taxpayer, because you had an administration that said, we're going to give you all these things. And we love our things. We love this, and we're going to give you all these things, but they don't talk about how it's going to be paid. And ultimately, they say, well, you're going to get a subsidy with regards to it. Well, it's shocking to me that somebody can make almost $89,000 a year starting next year. Okay, a family of four making $89,000, and they will receive a subsidy for their health insurance. So where does all this money come from? Well, it comes from the taxpayer ultimately. So there are going to be lots of subsidies in the exchanges to entice people. That's going to be the enticement. Their fear is that that's going to draw them away from the current private sector mark insurance and put them into the exchanges. And then the exchanges presumably are going to give you all kinds of choices, and they're going to reduce costs because of more people in them. But, when we talk about exchanges, I think the biggest example, we have two examples to look at for exchanges. Utah has what's called a shop exchange, where it's an internet-based thing. You go online, and it directs you to basically insurance agents who can help you with all the choices and everything else. And then there's the Massachusetts Connector. Now, the Massachusetts Connector has been around for 6 years. The irony is that the laws that govern the new exchanges that start in 2014, one of the big laws one of the big rules is that it has to be financially viable within 1 year. That's why Missouri has said, we have a balanced budget amendment in Missouri. We don't have a lot of extra cash. We don't want to set up an exchange. That's why we're going to opt for the federal exchange. In fact, only 20 states are opting for a state exchange at this time. The other 30 are going to either do a partnership, or they will have the federal government at least initially run their exchange.
On these federal exchanges, is the federal government putting up all this money?
Well, the federal, that's part of the administrative part of it. So to operate these and administer them.
Co-signer, in a state exchange, the legislature.
Right.
Is a co-signer on all this. But you're saying on the federal exchanges, the Congress is the co-signer to all this.
They may be the co-signer, but we're the funding mechanism ultimately. So
we get about 5 minutes here.
It would be disingenuous of me to say that everything is bad with regards to the Affordable Care Act. I mean, from a social perspective, is it good that everybody has health insurance? The answer is absolutely. Okay, but the question becomes how can anybody afford it? Now, I heard something that the president said just recently, that we don't have a spending problem. But well, if we don't have a spending problem, then when do we ultimately have a spending problem? We're going to spend millions of dollars with regards to these type of programs. I come back to that same thing that I said originally, is how do you insure 50 million more people? How do you give them, in some cases, better benefits, or at least quality benefits, not just basic benefits, quality benefits, and then have only 50% of Americans paying for it? It's just not economically possible.
Well, the president is aware enough to know that health care, government-provided health care, is the biggest driver of the American debt. I mean, prior to his administration, most people were saying that it was Medicare that was going to drive the American government into bankruptcy. Not Social Security, it was Medicare. And so somehow, and I've heard him say this, he's convinced that the Affordable Care Act will somehow get these costs under control so that they aren't growing by leaps and bounds like they were before this recession, depression, whatever we're in. And in the future, even though everybody's insured, the price or the total costs percentage-wise each year will go up a fixed amount, a reasonable amount, as opposed to what it was doing previously. I mean, is that something that you could agree with, or you think that that's like not possible?
I think there's a lot of assumptions that, you know, again, I guess the best answer to that is we don't know. But you know, I've been in the insurance business since 1979. And I've been doing legislative stuff for our industry for about 20 years. And I see legislation all the time that when it's first initiated, I said, no one asked an insurance agent before they put these things, because they don't, you know, they are not working with the people. They sit back and they write these things in Washington, you know, and it sounds good, it's socially acceptable and everything else, but it's not practical in so many issues.
Now you work with these companies, right? You're not an
correct.
Employee. You work,
No.
you're actually an independent contractor.
Yeah.
Do you find, like some people say, that the insurance companies are somehow inherently evil, greedy people who are trying simply to make a profit at the expense of everybody else in the country? Is that is that your experience?
I have experienced it, but on the other hand, I experience so many people that are happy that they have insurance. You know, so I think the administration takes that first viewpoint that, you know, the insurance companies are bad. They enacted something called medical loss ratio last year, which basically says that insurance companies they have to spend, depending on the size of the group, either 85% or 80% of their premiums that they collect on healthcare,
right.
on paying not benefits.
Right.
Okay. Now, this is the government telling a privately held insurance or a privately held company. Forget about insurance. Just privately held in company that they can only make 15 or 20% in profit. And that doesn't include administrative fees, that doesn't include people like me, that doesn't include advertising or anything else. Even if you eliminated all that stuff, they could only make 15 or 20%. That's why I think the argument of, oh, you're going to have people jumping into the insurance marketplace when the exchanges come, so it's going to give lots of choices. That's not what happened in Massachusetts. Now they're down to 5 companies, okay? They had many companies before that. What's happened in Massachusetts, you know, before they started the connector, they had the lowest uninsured rate in the nation, and they still have it. But prices have went up, jobs have been lost, and it's one of the most expensive places in the United States to get insurance now.
We're going to have to pause there. Thank you very much. It sounds to me like, well, when I have more choices, I can usually find somebody who can get it to me cheaper. When I have less choices, they're in the driver's seat. But I guess we'll see over the next few years, won't we?
I guess we will.
Thank you very much for being with us. And to my audience, I've been speaking with Ken Schmidt. He's an insurance broker. He had some very interesting things to say. We'll see you next time. And by the way, this is also going to be on YouTube if you want to see it again and show it to your friends. Thank you.